Hey everyone, today we're going to be talking about head trauma. And head trauma has a special place in my heart because that's what I saw a ton of in the ICU. And I saw a lot of families go through lots of challenges that come with it, from just all the tubes and wires and all of the things that they see to just the long-term care impacts that come with them. So welcome on this journey. We're going to go through some pretty high-level stuff. We're going to pull in some stuff that you already know, and then we're going to give you some case studies to help you apply it. So let's get started. Let's talk about our objectives today. We're going to explore the impact of outside forces, what they have on our brain. We're going to adapt the interventions needed for care from the initial traumatic brain injury through the healing process. Discuss the ethical perspectives and challenges that come with traumatic brain injury, identify some social determinants and the role they play in the immediate healing to the continued health of the client with a traumatic brain injury, their family, and the community. And we're going to utilize advanced critical thinking for rapid decision making and intervention in care of a client with a traumatic brain injury. In order to get a traumatic brain injury, we have to have some pretty significant force. I know we've already talked about stroke and how that is a disease process, but traumatic brain injury is a complication of some sort of forceful impact happening to the head. That can be falls, which is probably one of the most common. Motor vehicle accidents, we see a lot. Violence, unfortunately, I've seen a lot of traumatic brain injuries due to violence. Trains, my kids used to think I was joking when I would come at home and say, don't try and headbutt a train or don't try and outrun a train but unfortunately we have a lot of injuries related to trains, either from people working on them or people walking on them and not paying attention that a train is coming. So we do see significant injuries related to trains. Sports, there's a lot in the news about concussions and CTE and all of this additional stuff that builds up. So those are like concussions that keep stacking that then create problems. So we have a lot of sports injuries that result in traumatic brain injuries. And then suicide. Suicide, unfortunately, one of the methods that is frequently used by men is gunshot wounds to the head, and those are usually pretty effective, but every once in a while we'll have one that isn't effective, and then we have to deal with the injury that comes with it. Let's take a few seconds to review the Glasgow Coma Scale. It's something that you all were exposed to in health assessment. I've seen people pull it in and out throughout this course. It's a quick tool. It's a really good tool to get that efficient data to you as the nurse, but it's typically used outside the hospital, as you can see by this graphic that it's an EMT paramedic prep. So it's one that they're going to use a lot. They say less than 9 intubate, so anything 8 or less intubate, because that means we're going to have a really big problem with motor response, verbal response, and we want to make sure we're maintaining that airway. This lets us know a good, easy baseline for our patients. There's some pretty basic types of injuries when it comes to our head traumas or classifications of injuries. And understanding the basic principles of the forces is important. I think one thing that's really important for us to understand is everything in motion continues in motion until it's stopped. And that goes for our bodies as well. And when we think about our bodies, we also have to recognize that all of our organs, including our brain, are floating or inside of it. And what happens when we come to a sudden stop, whether it's a seatbelt across us or a wall or the ground, the organs keep going until they stop. So like your heart keeps going until it hits your sternum. Your brain keeps going until it hits the front, and then there's always that backflow of the tissue. So we're going to talk about the different kinds of injuries that happen to the brain but just understand that's all the way through the body, that those forces impact all the way through our tissues. So even though the seatbelt stopped us from hitting the steering wheel or the windshield, our internal organs, our lungs, all hit the inside of our rib cage and our sternum. So let's talk about the different pathos and damage that happens when it comes to the brain. So as you can see in the image above me, that is what we call coup counter coup, like where the head goes forward and then goes backwards. So we talked about a little bit earlier that things are constantly moving until they aren't, until they are stopped. And so we see that where we see the injury on the front of the brain and the back of the brain because it shifted forward and backward. And so that's going to make more level of injury. Anything that creates a shaking is going to create that. So whiplash effects from car wrecks, unfortunately shaken baby syndrome, people who have gotten in something that's gotten in a fight where they've been hit in the front and the back and had a lot of force. In the other image, there's a baseball coming at someone's head, and that is much more that frontal injury, and we're going to have one level area of impact. Versus the gentleman to the side here with the brain with all the little red dots. That's diffuse axonal injury. And diffuse axonal injury is similar to coup contra coup in the fact that it's a shearing force, but it's the neurons that shear and break. And so the problem is you guys have to think about, like what we've talked about several times, of what the body does every time it gets injured. It swells. So for the baseball to the front of the head, we have one area of swelling. To the coup contra coup, you've got swelling in two areas, the front and the back. But diffuse axonal injury, you have microscopic swelling around each one of those areas where the nerves have been sheared. And then more toxins break down and cause more problem. Diffuse axonal injury can be as simple as a mild concussion that we see in sports injuries to as complicated as a vegetative state. It just really depends on how much injury is done and the level that is done. Now, things for concussions, right? We want quiet space. We want decreased stimuli. We usually don't give them a ton of water because we don't want to have those hypotonic solutions. You're going to hear very similar themes as we learn about how to work with increased intracranial pressure and working with those more complex patients. So it's very similar, just the next level. All right, let's talk about hematomas. Location, location, location. Location of the bleed matters. So when we talked about hemorrhagic stroke, it was a disease process. And hemorrhagic stroke is in the vascular space in the brain. So it's in the brain, right? So it almost creates its own pressure because it's in that vascular space. Whereas when we have a trauma and something getting hit on the head, we have hematomas. And when you look on the image here, you see the red and the blue. And the blue is venous blood, and that is a subdural hematoma. So venous blood, nice thing about veins is they're slower. They don't have as much pressure and force. So our venous blood systems are not as problematic as when we get into our epidural bleeds. We have been known to call our epidural bleeds the walking dead because oftentimes our epidural bleeds, it's an arterial bleed, so there's a lot of force. So they'll take a hit to the head, they'll be knocked out for a second or a little bit of time, and then they'll get up and sometimes they'll be really confused and agitated and physical. Other times they'll be like, I'm fine, I'm fine, I'm fine. And then they go to bed and they never wake up because an epidural bleed is kind of called the walking dead, because if we don't catch it quick enough, that artery just bleeds the pressure out. And with the subdural, it's underneath that dural lining, so it creates again that pressure, just what you need to stop a bleed. But when you have an arterial bleed, it's above that dura mater, and so then it will just bleed and bleed and bleed, and we'll miss it. So that one's a really big challenge for us. So most traumas are going to start outside the hospital unless you have a fall or something in the hospital, but most are going to start outside. So a couple things to think about as you're working with trauma patients. If you're outside the hospital, you're going to have to adapt to whatever environment you are in, whatever supplies that you have. The big thing that I want people to understand, though, that with traumas is to recognize that oftentimes with trauma, you have more than one body system that's involved. All right. So if you have a head injury, very rarely do you have just a head injury. You have a head injury and a spinal cord injury, or you have a head injury and like a broken bone or something like that. So there's always multiple things. When it comes to things like car wrecks, we will see people have head injury from hitting the windshield or the steering wheel or even just the airbag hitting them in the face. But then we will also have seatbelt injuries where the seatbelt has caused bruising and damage, sometimes broken ribs. Every once in a while we'll see like a spleen laceration or a liver laceration, and those can switch you from being worried about the head injury to being worried about a hypovolemic or a hemorrhagic shock because they're bleeding into their belly. So that can be really challenging as you're working with patients. Even though we're talking about head trauma, just understand that oftentimes there's more things going on. You're going to want to make sure that you really follow your first aid and your BLS protocols, get help, get things stabilized as you can. One thing to think about too is that blood isn't always the priority. Blood is messy, it's everywhere, we get it. But oftentimes blood can actually disguise the real problem. So make sure you're working through your process as you're working through these patients outside the hospital. Here's a quick little tool that we have talked about in some form or another in our first unit, and I wanted to make sure we brought it back in as we're working through these traumatic injuries. So I know you guys love ABCs. You always want to add the D for disability and the E for exposure as we're working with these patients, because again, you're not just worried about the head injury, but also all of the parts that are attached to the head. I would prefer that it had like A, B, or C, just because I feel like alertness is a very big thing for us to assess in that first space. But this is a really good tool. And notice that when it talks about airway and then looks at that life-threatening condition, it has airway blockage and cervical spine. That doesn't mean that's the order that this is in. It depends on what's going on with your patient, what you can fix quickly, what is going to kill them. So this is where that application piece becomes so pivotal. So remember, airway, breathing, circulation, disability, exposure, stuff that we went through when we talked about triage and ER stuff. But just now that we've got shock and all this other stuff we're adding in, we've got more on this list to be able to work with. We have made it to intracranial pressures. Yay! Let's talk numbers. So intracranial pressure, or ICP, is the pressure that is inside our head with our brain and our cerebral spinal fluid and all the blood flow that's through there. And it's usually between 5 to 15 mercury, whatever their measure is. But anything over 20 is bad. Now, when you and I sneeze, it goes over 20. It's not bad for us because it's not sustained. It's that sustained number that gets really important. If it's just fluctuating up real quick and down, not a big deal. But if it is sustained above 20, it means we're starting to see more of that pressure happening inside that skull, and we're starting to push that brain through our skull and starting to have problems. And there's nothing coming out, so we've got to really pay attention to it. So anything above 20, not going to be our friend. An ICP is a monitor that we'll put in the head, and we will have it hooked to the monitor, and we will set it all up. Again, it's a very specialty monitor that you'll get trained on if you go to a trauma unit. You'll see other things that we can put in people's heads, like ventric drains and stuff like that, where we'll have a drain and it'll be hooked to like a bag and stuff, and we'll be draining fluid because Either they aren't draining out their cerebral spinal fluid, or they have some pressure issues that we can kind of contain with just the fluid. But any of your head trauma patients that we're really concerned with, we're probably going to put in an ICP monitor so we can see what's actually going on. Now let's talk about cerebral perfusion pressure. This is the pressure of blood flow into the brain. So you can think about, as the brain is encased in the skull and swelling due to the injury, it's going to take more pressure to get the blood up into the brain to keep the perfusion going to the brain. So while I've got the math on here that it's MAP minus ICP equals CPP, that has way too many P's. You don't need to know that math. What you do need to know is that we have to have blood pressures be more elevated with our head trauma patients, because we need to be able to push blood up into an area that is already kind of congested with inflammation and damage and all of that. So we've got to have more pressure. So oftentimes we will keep their MAP between 80 and 100. So I know when we've talked about blood pressure monitoring, we'll be like, ooh, a MAP of greater than 65 is good. Well, again, it depends on the level of injury and the illness and what's going on. We really want the CPP to be 60 to 70, but the MAP then needs to be 80 to 100 to effectively perfuse the brain with all the inflammation that's going on. So just know that you may see a higher titration of pressors because we need to get stuff up there, because in order to keep the tissue alive, we've got to get blood flow and oxygen to it. So that can be a challenge as we're working with them, because we don't want them too high because that'll cause damage, but too low, we're also causing damage. So it can be a fine line and be a really big challenge to work with. All right, I really like this cartoon because I think it really helps pull in all the aspects of what it looks like to have increased intracranial pressure. So I'm going to tell you, the first thing that you will see is changes of level of consciousness. I know it's not the big fancy stuff, right? But it is honestly your first probable predictor of that all of a sudden there's more swelling and stuff going on because they're changing. Now, if they're sedated or paralyzed or any of that, you're not going to see those symptoms. So then you're going to have to look for other ones. But if you're just out and about on the bike path or whatever, and all of a sudden you see somebody who's hit their head and they're doing okay for a little bit, and then all of a sudden they're getting slurred, they're like just not quite able to pay attention, there's more swelling, there's more injury going on. Headache, if they're awake and telling you that. Eyes, usually looking at like if they're getting bulgy. This is where it gets really interesting. Pupillary changes. So while I make you guys check pupils all the time when we're in the ICU, it's also because it tells us more than that. But if you are seeing pupil changes, we've missed something. Like, that is one of the latest signs. I know, like, all the TV shows, like, oh, their pupils are blown. Yeah, no, that's a really, really late sign. We've missed a lot of other signs of injury in there. Posturing, that decorticate, bringing it to the core, or decerebit, where we're extending our hands, we're extending out, or flaccidity, all can be things that we might see. Seizures, we will see, especially can happen quickly after a hit because they get all, like, their brain just kind of goes a little haywire, or that can be prolonged with injury and the swelling process. Vomiting, I call it neurovomiting. Watch out, because it's not like a vomit, like, well, I don't feel good, blah. It is like, they just sit up and they projectile vomit. And I've had patients like hit walls before. It is like, I don't know where it comes from their toes or something, but it is just like straight out. So don't stand at the end of their bed, because you're going to get caught if you do. The one thing that NCLEX loves to ask on is the Cushing's triad. And that is where the blood pressure will go up, the heart rate will go down, and they have an altered respiratory pattern. So think about what you are working with an altered respiratory pattern. That is not lung sounds. It is respiratory pattern. That's why it's really important for us to understand when we're doing head to toe assessment that we're looking for the ease of breathing and the regularness of breathing, because breathing is one of the first symptoms or first signs of any change in anyone. And we miss it often because you'll often see, oh, well, they were respiratory rate was 16. And it's like, was it really? So really big thing to pay attention to. Cushing's triad: increased systolic blood pressure, decreased pulse, and altered respiratory pattern. But it's not going to be a first sign. A first sign is usually going to be your change in your level of consciousness. Another thing that you want to think about with different populations is how it's going to look with our elders. Our elders have a little bit of brain atrophy just from the aging process. So their brain actually has a little bit more room to swell. Alcoholics, they have a little more room to swell because they're dehydrated from their drinking. So it gives us a benefit. The only challenge to that is alcoholics also have challenge because alcohol makes your blood not coagulate. So they have more bleeding, but they have a little bit more room. The one on this little cartoon that I think is really important for us to pay attention to is infants. Understanding that with infants, when they have head injuries, especially like you're talking about like your shaken baby, or maybe your kiddo that like rolled off the changing table, or fell off something, the counter or something, whatever, right? Kids do crazy things. The bulging fontanelle, because again, they have that increased pressure, so they're going to have that bulging fontanelle. Understand that fontanelles usually close at a certain time. I think it's around 12 months, but I'm going to check on that to make sure I get you the right date for that. So if you have a bulging fontanelle, it's going to be in an infant. It's going to be in somebody small, right? So that's when you can check like head circumference and all that other stuff. Once our sutures have well fused, you no longer will have that bulging fontanelle piece. You'll have these other symptoms. The other thing with infants that is really just super eerie, and if you ever hear it, you never forget it, it's the high-pitched cry. It is so eerie and so just visceral, and you just know it when you hear it, and you're like, whoa, we have a head injury. So that's something that we always want to be like paying attention to, is like using all of our senses as we assess these patients. The least fun part of my job is what happens if we don't get the swelling under control. So we have to think about the physiology, the anatomy of the body, right? You've got a skull that's encapsulated, and then you have tissue inside that's swelling. There is only one place for it to go if we don't get this fixed, and that's down. And you can see in this image, you've got like the pons and the spinal cord, which are all part of that very core part of the brainstem. And if the brain is continuing to swell, it will push it out through the spinal cord, or the magnum foramen, which is the base of the skull. And this becomes really challenging. At that point, there is no saving. At that point, you are considered probably brain dead. So there's no fixing once that brain has shifted out of that area, and that is not a good day for the family and everybody going through this process. So it becomes really, really important that we recognize when the swelling is happening and we get it changed, or we do what we can to get that under control so that we don't have to deal with that. Unfortunately, there are just times where we just don't get to people fast enough, and that does become the outcome. Let's talk treatment, because that means we can do something about it. So we're talking about the treatment of increased intracranial pressure. The first easiest treatment for us to do is alignment. alignment from head to toe to keep everything in alignment, because you've got to think about it. That cerebrospinal fluid washes over our brain and around our spinal cord. So all of that system is very, very interconnected. And I want to make sure that we're paying attention to that with patients when we turn them, when they've slowly slipped down out of their bed, and they're bending in the wrong spot. We'll see it. We'll even see it just when their head's kinked and tilted to one side or another, like their ICPs will start to climb. So that's something that we're always kind of challenged and working with. Other things we can do is elevate. So while most of our patients, unless they have a spinal cord injury, we're going to elevate them at least 30, head of bed 30, if not 45. I don't see it used a ton much anymore, but I used to see tilt tables where we would strap people into a table and we would lift them up and they would stand straight up, and they would be strapped down. So I don't see a ton of tilt tables anymore, but that was a practice for a while and may still very much be in those areas. Pain and sedation management. So these patients, we don't naturally put them on paralytics. So unless there's something else going on like seizures or any of those kinds of things, but we do have them on pain meds and sedation management, because especially if they are on if they're vented and all that kind of stuff, we don't want them to be uncomfortable and wiggling in bed, trying to get themselves comfortable. So we're going to give them some sedation and pain management. So we need to assess to see if we think that that is the reason why they're being really restless. Other things that we can look at are our fluid volume. So this gets really interesting. If you ever go to a bar and you see that they give you popcorn or they give you pretzels for free, oh, that's so nice of them. No, they're playing with your fluid and electrolytes. So keeping you dehydrated makes you thirsty, right? Your cells shrink. Well, when we have a head that doesn't have a ton of space for fluid to swell into, we want to make sure that we are keeping it as dehydrated as possible. So we will limit hypotonic solutions. So water is not our friend for most people with our head injuries. So we might give them like Gatorade with ice or something like that, but we're not necessarily going to give ice water. And so we want to make sure we're looking at that. Otherwise, 3% normal saline. So normally we give 0.9 is normal saline, and now we're going to be giving 3%. It does require a nurse double check because it's so concentrated in sodium, and we want to make sure we're also looking at those labs with that. But 3% is something we might give. I might also give mannitol to help get the fluid out. So that's a diuretic. We're going to give you mannitol to try and get some of that fluid out, to try and bring down some of that increased intracranial pressure. Another one is to decrease stimuli. So this is one where when we're talking about a family that's fighting, they don't get to do it in that room at all. You might have the lights turned down low. You might not have TV on. You might have some music, but maybe not. We do not want extra stimuli. One big thing of stimuli that we get is touch. So touch is very, very healing, and it serves lots of purposes. But when we work with our head injury patients and we've got these parents that are seeing their loved one with all these tubes and wires and they feel so helpless, touch is very healing for both of them. However, we cannot pet the patient. When I mean like petting the patient, we want to make sure that they can hold the hand, right? But they can't necessarily just pet the brow and touch and do all these things. That is creating, all of this has nerve endings. All of the nerve endings connect here. We do not want that. We want to decrease that piece of it. Other things we can do is hyperventilate. I'm not exactly sure at this moment how that works, but it probably has something to do with blowing off some of the CO2 and bringing down some of the acid and helping with some of that balance. It's not something we're going to be able to do for a prolonged period of time, but it might buy us some time while we're waiting for swelling to go down. Another thing is cooling. This is a very specialty field kind of space. If we're cooling somebody, we're going to paralyze them, because if we're cooling them, we do not want them to shiver, because that means they're increasing their stimuli, but they're also burning a ton of calories that they need for healing. So we don't want that. So if we're going to cool someone, it's usually a 3-day process. We get them down within like 4 or 8 hours, depending on the protocol, and we keep them down. And we're usually down anywhere between 93 to 91 degrees Fahrenheit. So we're keeping you pretty cool. We do not want you to shiver, so we paralyze you. So we have to do a lot of family education with that. But that's going to be something that you're going to see in a very specialty area. We do teach, like the life flight nurses and all of them, to do ice packs on the neck, armpits, and groin, to start getting that cooling process going if we think that this is a cooling type patient. Not a treatment for increased ICP, but something I did see in the literature is that antifibrinolytic is now something that we're giving. I don't remember giving this when I was in practice, but new technology, new meds. So that is to keep the clots built so they don't dissolve, so that we can get the bleeds to stop. So something to kind of think about as that if we're needing the bleeding to stop. So what if we can't get intracranial pressure down? That means it's time for surgery. So, and usually this gets very hurried because we've been watching the monitor rise, we've been watching the symptoms get worse, and so we know that the level of swelling is too great for any of our current interventions, and we have to step into surgery. So, craniotomies, we can do them on one side or both sides. We call it T-topping if we do it on both sides. The other thing to think about when it comes to craniotomies is if the patient, say they got hit with a 2x4 in the head that cracked their skull, that may change whether we need to do a craniotomy, because they may already have an opening. We may just have to go in and kind of clean up some of the skull fractures. So depending on what's going on, but if a closed head injury happens, we are going to need to do a craniotomy if we can't get the ICP under control. So what goes into post-care, because pre-care is going to be all the basic stuff that you guys have learned with surgical, consents, and making sure we probably have blood type and crust, and we have, an H&P, and we have the most common or the most up-to-date records and meds and all the stuff. So all that's going to be all your pre-surgery stuff. But your post-care, one is going to be pretty typical of post-cares, other than they're probably going to be on a ventilator. They're probably going to be getting fluids and all that kind of stuff. But you're going to have some of those typical post-ops. You're going to have the supportive cares. You're going to have a lot of the same types of interventions that you had with your increased intracranial pressure, because we still want to keep some of that pressure down. We're going to elevate the head of the bed, right? We're going to protect the side that had the cranie on it. So there will not be skull on one side of their head, and we will want to protect that. So you won't want them like laying on that side. Remember, the brain is the consistency of Jell-O, so it's really soft and pliable, and you can literally kind of feel the brain once they've got that skull open, and you will see it like really swell out. They get so huge. It's just kind of crazy that they can have that much swelling. Long term, they're going to have a helmet, but that's going to be a while. Kind of a cool fact is where they put the skull flap, right? Like where they put that skull flap. They actually stick it in the abdomen is where I have seen them stick it. Is they'll cut a little incision and they'll put it in the abdomen. Why do you think they put it there? Kind of interesting and kind of funny. It's so it doesn't get lost. So when you think about these patients that have head injuries, we're not going to put that flap back in till probably long after they've been in rehab. And they've been bouncing around between different hospitals and different rehabs. And so we can't even keep dentures, people lose their dentures, they lose their phones, they lose their hearing aids. Like, this is not a piece of tissue we want to lose. So it actually is just more just to keep it safe so we know where it is. So if you're ever working with a head injury patient who's had a cranie and they have an abdominal incision, and remember we talk about palpating that abdomen, and they're going to have a firm spot. That's part of that skull. Now, if they've had a head injury where the skull was shattered or there were parts, we won't put that in the abdomen. We'll just take that out, and then we can use, they can use different metals and stuff to make a new skull flam. The challenge with that is that it's external. I mean, it's a piece of hardware, so the body can reject it and all that kind of stuff that goes with anytime we put something external in the body. Most of the time they don't seem to have too many problems with it, but that's one of the reasons why if we can keep the skull and we can put it in the abdomen and keep it with them, they can go to rehab. Once they're ready, we can then put it back in and we don't have nearly as many complications with it. But cranies, the same as most of your surgeries. We're gonna just take out that thing or take out that skull. We're gonna put the skin over it. We wanna make sure that we're just really safe with that exposed brain. It doesn't have the safety of the skull on it anymore. Let's talk about some complications. Now, these are mainly the medical complications. We're not talking about the social, financial, or any of those at this time. Just we'll talk about those here in a few more slides. But right now, we're going to talk about some of the complications that come with a head trauma. So seizures is a big one, right? We've had a level of injury to the brain, and it is now causing, I think of it as a lot like AFib of the brain, right? It's just a wire gets misconducted and it just goes kind of wonky, and then it goes wherever that nerve is connected into the body. So think about your seizure precautions. You want to have suction, you want to have padded guardrails, you want to have oxygen at close to or at bedside. So those are like your seizure precautions. Then we're going to think about safety. So when someone is having a seizure, be safe. Depending on the level of a seizure, there's everything in seizures from like absent seizures where they just sort of disappear and they're like, hello, no one's home, to full grand mal seizures where they are having tonic, clonic, massive moving, contracting muscles. They are moving things so forcefully. I have had patients that have broken their own arms because they were having such a constricted, like seizure-like motion, or they've dislocated their shoulders. So safety, safety, safety. Do not stick anything in their mouth. I know the old wives' tales and adages of like a spoon in there. Do never put your finger in there. Please don't ever put your finger in there. I don't care. Their tongue is their tongue. If they bite on it, if they bite your finger, just don't stick anything in there. It just adds more danger into that airway. If you can turn them to the side, great. From what I've experienced with seizures, most of the time I can't because they're wiggling and they're moving and contracturing so much. There's nothing I'm going to be able to do to move them. Most of the time, you just have to let them be. You kind of clean the area around you or around them so that they're not hitting anything. If they're, in their recliner, you may lower them to the ground, right? Depending on the level and the severity of the seizure. Big things, just keep them safe, keep you safe, and protect the head. The other thing with seizures is document the time it starts and the time it ends so that we know how long a seizure is lasting. If seizures are lasting more than a minute, 2 minutes, 3 minutes, we need to probably get some meds on board, some of the emergency seizure meds. So then you're looking at, usually Ativan is the one that I've seen used the most, where we're going to use Ativan to stop the seizure. It can be rectal, or it can be IV. A lot of times you're not going to get it in before the seizure's done, but hopefully it'll prevent the next one because they can kind of have some little seizures after it. The other thing you want to document is what you saw. So I had a nurse one time that documented that a patient had a grand mal seizure. Grand mal is like the big kahuna of seizures, right? That's the full, like what we classically see as seizures. Lots of movement, lots of muscle jerking, some agonal breathing, that kind of stuff. when I asked her later, mind you, she'd called the family flew up here from Texas to come see their dad because he'd never had a seizure in his life, so they didn't know what was going on. And when I asked her, she goes, well, we were cleaning him at like 2 a.m. And when we pulled the blanket back, he got stiff and put his arm up real tight. And he got rigid. And I'm like, I'm not sure that's a seizure. It's definitely not a grand mal seizure. It could have been that you startled him out of his sleep and he was cold because you exposed him and he was wet. And so document what you see, don't diagnose. Just say what you saw, if you saw it start somewhere, if you saw the stimulus that happened, those are the things that we want to think about. If we have somebody who's having lots of seizures, we may need to get the internal implant thing put in them. If it's somebody who's in our rehab era of a head trauma, we may need to get some of those internal kinds of things put in. We've also got medications, and this is probably another big one that I want you to think about with medications with seizures. You do not stop them. Okay, I know we do NPO and we do all these things. These are things that if a doctor orders NPO and you're like, but we have seizure meds, you want to make sure you get the doctor to say whether they want you to give those or not, because those are things that we want them to make sure that they're having those medications. We had a patient at one of the hospitals I worked at where the patient had been NPO for like 3 days. No one addressed the seizure issues. The patient had a massive seizure and died from the anoxic injury. And we never gave the hospital staff never gave the patient their seizure meds, and it just kept getting passed from one person to another, and no one actually took accountability for it. So big thing, give those seizure meds. So I've kept her on there. It's pretty classic. There's some other ones out there. Nimitop is one. There's a whole bunch of new ones out there too. I was just looking today and saw lots of new ones out there, but the big ones are, you're going to have your seizure status quo meds, and then you're going to have Ativan, which is going to be your emergency seizure meds. So somebody who's having a prolonged seizure and we need to get it under control, we're going to give those. Another complication of head trauma, and one that we see more in the ICU level, is diabetes insipidus. This is not diabetes, has nothing to do with insulin, has everything to do with that dang pituitary gland in your head. And as your brain is squishing and pushing on that pituitary gland, it lets out a whole bunch of hormones and they pee every liquid out that they have. So I have watched patients void out all their electrolytes and then have big complications on the other side of it. So we want to make sure that if we're seeing diabetes insipidus, and when we say pee, they're peeing 600 an hour, 800 an hour, and it is clear, barely a tint of yellow in it, and they're putting out a ton. Big thing we're going to do with that is we're going to replace the fluids. We may even get orders to 1-to-1 it. If they're paying out 600 this hour, you're giving a 600 normal saline bolus to replace that fluid, plus all the electrolytes that they're losing. Now, there is a drug, desmopressin or DDAVP, that works really well to stop diabetes insipidus. But again, we have to recognize that it's happening, and we have to recognize that we need somebody to help us and get it going, because this does kill people. And if you lose all your fluids and electrolyte, we go into a shock-like state or into a dysregulated heart because of the electrolyte imbalance. So we need to get the diabetes insipidus controlled. I typically see it with head traumas. I'm sure there's some non-head trauma things out there, especially because it's the pituitary gland. So I'm sure there's some hormone things that happen. But when I have seen it, it's been with head traumas. So just a real quick shout out on SIADH, or symptom of inappropriate antidiuretic hormone. This is something NCLEX loves. It loves to ask questions about SIADH and diabetes insipidus. And I can't say that I've ever really seen SIADH. It's more just a fluid hormone issue, where diabetes insipidus I've seen more with the head traumas specifically. But this is something I want you to be aware that they are almost kind of opposites of each other. But NCLEX does love this question. So make sure you at least review it and you understand what you would see, what you would assess for both of them, just so that you're feeling prepared as you prepare for NCLEX. Like I said, diabetes insipidus I've seen, but the other one, I just haven't seen it that much. I'm sure it's much more of a chronic illness or a chronic condition rather than a traumatic one. What are the next steps? Rehabilitation, end of life organ donation. So this is where we really have a split in the road. Rehabilitation, really intense for several of these patients, depending on the level of head trauma. Some people just need a little bit more help putting thoughts together, while some people have to learn how to walk again, learn how to talk, or just learn how to function in their everyday life. And then we have organ donation or end-of-life processes, and that has nuances and complications of its own, a lot more family support, and understanding the processes of organ donation. So long-term traumatic brain injury care is complex and can be really long. Again, like I talked on the previous slide, it may be simple, where they're just learning how to kind of connect their thoughts or maybe read or write again, versus we can have people that need to learn how to function. They need to learn impulse control. We see a lot of what we call frontal injuries, especially with that whiplash motion. And so those patients have really poor impulse control. I had a patient one time that it would say everything in his mind. So when they took him out shopping, he walked by somebody who had toilet paper in their cart, and he was like, well, you must poop a lot. And he used profanity words. So you can imagine how shocked this little woman was who was trying to buy some toilet paper. So that can be really challenging. Other parts that can be really challenging with these patients is it can change their personality. I know we think we love with all our heart, but everything of who we are is here. And so when we have injury from swelling, when we have hypoxic tissue issues, any of those things that can cause long-lasting challenges, it can be very hard for families to deal with. We had this little lady who fell and hit her head, and she had never cussed a day in her life, and she cussed like a sailor. So the family really struggled with that. So big things with our patients with long-term traumatic brain injuries is so good supportive care. So if we're going to a rehab facility, we have Madonna is an excellent traumatic brain injury rehab here locally, but there's some really good ones all across that work extensively with those types of injuries. And we're going to need that support because it is a long road. It is not a short and quick healing process. Extensive rehab, depending on the level. Like I said, they can have to learn to walk again. They can have to learn to pay bills again. I mean, it's just huge. And impulse control becomes such a big part of head injuries. Other things that I've noticed with head injuries is they don't seem to understand like high level thinking after it. We had a young man, unfortunately, close by that went to my kid's middle school who got hit by a drunk driver at 7:30 in the morning. The kid was riding his bike to school and the guy hit him. And they unfortunately found the guy that hit the kid, but the kid, while he survived his injury, there was long-lasting effects. And like I remember the woman saying on the news how they had to have lists for him, and she goes, he took my son because my son is no longer the same kid he was prior to the injury. So it's very, very extensive, and can be very, very hard. So big family support. They just need a ton because their loved one, as they knew them, is no longer, and so they are going to need that support, and then they're going to need to adjust to the adapting to that new life of, if that person was the main breadwinner of the family, they may not be able to be the breadwinner of the family anymore, right? So that gets really challenging, and it becomes family care. And think about the socioeconomic components that go with that. If you are financially stable and have the ability, how much different that care might look than somebody who can't build a ramp for the wheelchair to come into their house, or doesn't have ADA compliant bathrooms, or doesn't have the ability to financially afford the extensive rehab and the follow-up rehab and all of that. So this is an area where it gets really, really tough for families because it's very financially costly. And if you're the breadwinner, if that person was the breadwinner of the household, that could be a huge impact as well. So understanding all of those things and the ethics that go with some of these conversations, because some of these patients aren't rehab appropriate because they're in a vegetative state. And so we have to have those conversations with families too, that they're not going to get better. They're not going to wake up like they are permanently in this state. And then there's a lot of ethical conversations that go with that on what is true quality of life and what is living. And each family and each person gets to decide that for themselves. I would strongly encourage you to discuss that with your family as well, of how you define living, so that if they ever have to make tough decisions, they have your words to know that what your thoughts were on living, because this is where that rubber meets the road a lot of times, is once we've done all these cares and we've done all these amazing things, was it worth it? And that's a very personal decision for lots of families to understand. But these patients can be on ventilators for the rest of their life. I know we have a patient that I used to work with at a rehab facility that was on a vent. She's in vegetative state. Her family wouldn't let us make her a no code or do anything, right? So she was full everything, but she never really could look at us or anything. Like, she was in a vegetative state, and that wasn't going to change. So, and family didn't come to visit and all these kinds of things. So it was just really hard to see. And so we want to make sure that we're really educating our families on what we think the prolonged outcomes are going to be. If, again, we don't have a crystal ball, but that understanding how you define living is very important before we have the injury to our brain. So let's talk about something I am incredibly passionate about, and that's organ donation. I used to work with the Live On team a lot in the trauma units, both in Omaha and in Lincoln. So I got to know the team really well and became one of the Live On specialists in our unit. So I just helped when we had new people come in learn how to do the organ donation process. So first we have to understand there's two types of death: legal death, that's brain death, and cardiac death. The client or the patient can be brain dead and still have a pulse, right? And in fact, that's what we prefer, because we can actually take or get more organs out of that. But it is a process to get declared brain dead. When a patient is declared brain dead, that is the time of death that is put on their death certificate. So while it takes probably 3 additional days to get everything put together, to get the matches and all that kind of stuff done, the time that is on their death is the time that they are declared. So a provider is going to declare a client or a patient brain dead. That's not on nurses to do. We do have our own rules, and then we are able to get all viable organs from that person, and it's a really cool process, a little surreal to watch if you ever get the chance to watch an organ procurement harvest, is the inappropriate word, but it's the only one I can think of. And so it's just a really neat process to watch. It can be very hard to watch, but it's super cool. I got to watch a 17-year-old kid donate, and they opened him up and they get everything ready because all of the organs have a different, what I would call a shelf life, where they need from cut time to reperfusion time. And the heart, I believe, is 4 hours. So from cut time to reperfusion, you got 4 hours. So they dash. Like as soon as they cut, they dash. But they got this 17-year-old kid ready to go, and they opened his chest and they were looking and doing all this stuff. And the girl in all scrubs like looks over, has her phone, and says, "Yep, get her ready. It's good." And so a 16-year-old girl in Arkansas was getting a new heart that night, and that's just like so cool that we can do those kinds of things. So with cardiac death, it's a little bit different. Cardiac death is more going to be a compassionate extubation. We allow the patient to pass. Usually it's going to be in the OR, so that once they do pass away, we have a very short window to get some of those organs out, because those organs have taken a hypoxic hit, so we can't take all of them. We can take the kidney, the liver, and the lungs. We didn't used to be able to take the lungs, so it's pretty cool that we can take the lungs now. And these are like the organs. There's a bunch of tissues they can take and do amazing like grafts and all that kind of stuff for like people that get ACL repairs and all those kinds of things. So there's a lot of tissue stuff that they can do, but these are kind of the organ pieces that we can do. And so I did provide you all with the PowerPoint that is specifically the Live On PowerPoint, and I just kind of picked the quick synopsis pieces. But how it works with cardiac death is donation after cardiac death. The patient has, from the time we extubate them, they have an hour to pass away, and then we wait 5 more minutes after they've been declared dead, and then they will take the organs that they can. So family will sit in the OR with them and be with them just as they would at the bedside. But then once they pass away, we give them a few minutes, and then we get them out of there, and then we can get those organs out so that the surgeons can go on and do their thing. A lot of times this is in the middle of the night, just because the docs have procedures all day, and that's when all the ORs are open, because they're balancing air traffic, road traffic. They're getting through all of those pieces, the ORs, the different staff and team to get it going. So pretty cool process if you ever get to watch it or see it. Live On Nebraska does a lot of fundraisers and cool things, so if you get a chance to go see some of those things. I couldn't figure out whose Iowa's was. I looked a little bit and I just wasn't sure if that was who theirs was, so I didn't want to say, but each one has their own kind of area, and then organs can only go so far out too. So because there's that shelf life time isn't going to let them go any further. So just want to talk real quick about cranial nerves. So this is why cranial nerves are important as we work with declaring a client or patient brain dead. Those cranial nerves are what we watch. So the gag, cough, and corneal reflex, where we touch the eye and the person either blinks or they move away from that, is the corneal reflex. Those are cranial nerves 9, 10, and 5. But those are the things that we're going to look at. And if any of those disappear, you have like 1 hour to notify the organ procurement group. The nice thing about them is they really prefer if you just notify them earlier so they can get on board. They would rather have work done and not need it than be scrambling at the end to try and get stuff put together. But the cranial nerves are really important, and as you can see by this drawing, the cranial nerves are very much in the middle of the brain. So that's why they are a good indicator of the brain function, and if they have problems, that means there is issues with the brain. And again, gag, cough, and corneal, those are our 3 real big indicators of we've got some pretty very central brain function that is not working. So let's explore the nurse's role when working with an organ donation patient. The first rule, do not approach. So it looks like an ethical conflict of interest if I approach a family and ask if they want to donate their son's organs if I am their son's nurse. So that looks like a huge conflict of interest. People already think we don't treat people so that we can get organs. Well, here's the deal. I need those organs well perfused. I need those organs oxygenated. So people get amazing treatment if we think we're going to donate organs. I mean, we give amazing treatment anyways, but if we think we're going to get organs out of them, we really want those organs nice and healthy, and they get lots of tests to make sure those organs are in really good form. So that's one of those things. It's just, we cannot approach. If the family approaches us and says, hey, my son is not going to make it, and I'd like to see about donating his organs, that's when you just say, let me get someone for you. It's the one time I will be like, you can kick this one off to someone else, because it just looks like such a huge conflict of interest, and there's so many nuances and rules and regulations to it. You don't want to say, yeah, he could totally donate those organs, and then them come back and find out that he can't, because that is really crushing for a family who wants to give that last gift. So we do not approach. Doctors do not approach. There's usually a couple people in the hospital who are trained and certified or whatever they do to approach families, but usually it's going to be the people of the organ donation team that will approach. So whoever is part of that procurement group will come and have conversations with them. Things we have to do as nurses: we have to notify the organ procurement group. For us, it's Live On Nebraska. There's lots all over, but we have to notify them within 60 minutes of if we have lost that gag. So if we've lost the gag and we're like, ooh. Now, if your patient's paralyzed, you don't know, because we have them paralyzed. So once you unparalyze them, then if they don't have gag, cough, or corneal, then we need to notify them. They would rather know sooner than not, because it's a lot of work to get people matched and to get things going. So if you know, or if the patient's family is thinking they are going to extubate or do any of that kind of stuff, then we need to get them involved, because they need to step in. If you have signed the back of your driver's license to say that you are an organ donor, that's like first person permit, so your family actually can't stop it. It is a legal document, and so they will step in. Now, they're not going to arm wrestle people to get a loved one's organs, but if it's good solid organs and it's like a 30-year-old and that's what you wanted for your end of life, or they wanted for their end of life, they're going to push for that. And they have so many people on their team, and it's just really amazing how beautifully they work with people. They have social workers, they have therapists, they have all of their team is so cool to work with. So the other thing is that you're going to just care for the patient in the ICU until they're ready to take them down to the OR. So you are going to do cares, but instead of getting orders from the hospitalist or the ICU intensivist, you will actually get your orders through the organ procurement representative. They have a doctor on staff, and they will write all the orders and stuff. So there's some different nuances to different orders. They want to keep certain organs perfused at a certain pressure. So there's some nuances to that. But just know, we do not approach. We only get an hour to let them know if there's been changes, or if there's families talking about extubation. We've run into some complications. We had a patient at a long-term vent unit that the family decided they wanted to do a compassionate extubation, and before that patient had been in that state, they had signed the back of their driver's license. And so all of a sudden we had to transfer a patient from a long-term vent unit to the hospital to get extubated, so then they could donate the organs, because that was their wishes. So you can imagine if family thinks they're going to extubate, in the next 2-3 hours, and all of a sudden you have the organ donation team coming in, they're going to be a little off put. So get them involved way early. Like, they would rather just decline the case than not know about it. Thanks everyone for a fun day of learning. I hope you had fun with this, and please reach out if you have any questions that you need me to clarify or answer. I know there's lots out there when it comes to head trauma, so I've just tried to give you some very solid basics to help you build from. Have fun, and there will be a case study to help wrap all this up together.